Good morning and welcome to members and officers and public to Health and Adult Social Care Overview Scrutiny Committee today, the 12th of July. Before we start the meeting proper, I just need to inform you that this meeting is being live streamed and recorded. And welcome to the portfolio holder, Dean Carroll, who will be joining us via Teams. Apologies for absence. We have 3 apologies for absence. David Minnery, who's substituted by Ed Towers. And as if by magic, he comes through the door at that time. Welcome, Ed. Okay. And then we've also had apologies from Dan Thomas and Roy Aldcroft. Item 2 on the agenda, disclosure of pecuniary interests. Are there any such pecuniary interests that need to be disclosed? No? Oh.
I think my usual, just working at GP surgery.
Yeah.
Yeah.
And I suppose my usual one as well will be the fact that I'm doing bank for RJAH on the vaccination centres. Item 3, minutes of the meeting held on the 14th of June 2021. We have all had that electronically. Are we happy that that is signed as a true and accurate copy of the minutes? It's been moved and seconded. Okay, those minutes are accepted then. Item 4 on the agenda, public question time. There are no public questions. And members' question time, there are no members' questions. So we'll get straight into the nitty-gritty. Item 5, Shropshire Joint Strategic Needs Assessment. And Rachel, welcome to the meeting.
Thank you very much. Thank you. So the paper that I brought to the meeting today is an update on the previous paper, which I brought to Scrutiny back in January, which was an update on our Joint Strategic Needs Assessment. The paper provides an update on where we are with our Joint Strategic Needs Assessment. So the last paper was brought to the board on the 25th of January, but I'll just give a bit of context for the new members who may not be aware of the work that we've been doing on the Joint Strategic Needs Assessment. The Joint Strategic Needs Assessment is a statutory requirement that we need to produce. That every health and wellbeing board needs to produce on behalf of its population. It's done at a local authority, local authority area across the county. There's various elements of that are required, which come into the statutory obligations, and what I'll do is provide an update onto where we're at as a health and wellbeing board in producing this document. There's several elements to the document. So if you remember, back in 2019, we decided that we'd update our Joint Strategic Needs Assessment priorities. These set the priorities that we need to deliver improved health and wellbeing outcomes across the county. So that work was undertaken through various workshops with the Health and Wellbeing Board, and we reset our high-level priorities around health and wellbeing across the county. There was then 3 specific needs assessments that we were required to undertake, because these are historic, we'd run out, they needed to be updated and produced. And that was a shared consensus across the Health and Wellbeing Board. So one piece of work was a MSK needs assessment that has been produced and delivered. There was a second piece of work that was required, which was called at the time Older People's Needs Assessment. So it was across Shropshire in collaboration with the CCG. But the third element was to update our SEND, our Special Educational Needs Assessment. That work became stalled because of COVID in essence, but that work has been updated, and I'll give you an update on where we're at with that SEND needs assessment. It's one of our key priorities. So those were the 3 specific needs assessments we needed to produce following the update of our overall priorities. And then we have another statutory requirement to produce as a health and wellbeing board, which is our pharmacy needs assessment. This is it's an assessment that we have to produce every 3 years. That's mandated to us by NHS England that we need to produce that update. As I said, that is produced every 3 years across. It has to be produced across the county. That was deferred last year because of COVID, but again, we are now required to update that for March, the 31st of March 2022. And then the final element of our needs assessment approach that we undertook following agreement with the Health and Wellbeing Board and partners was that we would produce a very detailed update of all of our priorities and what we've called our place-based joint strategic needs assessment. And I'll give you an update on progress around that. And that's outlined within the paper. So I think the first thing to draw your attention to is the SEND needs assessment. So our special educational needs assessment, as I said, we had to restart that. We had, as a priority coming out of the inspector that came and visited Shropshire in terms of the SEND needs assessment, we knew we had to undertake this piece of work, and we restarted that earlier this year. We brought in additional resource to help us deliver the special SEND educational needs assessment, and we have now got a draft of the document that has been produced. This has been produced collaboratively with all members of the SEND partnership and through with the Health and Wellbeing Board. It's a 100-page document that's been produced. It covers within the document risk factors. It profiles our SEND population in terms of characteristics of that population and some of the health needs of that population. And there's further development to do to finalise the document in terms of bringing in additional quantitative and qualitative data, and particularly around family voice and young people's voice, to make sure that comes within the document. There's also some recommendations that have been developed, but further recommendations are being developed. The draft is now with the partnership groups, the task and finish group, who have been undertaking that, but you can see that progress has been made, and we're at the point where we hope to have the final document produced next month. So that's the SEND needs assessment. The pharmaceutical needs assessment, as I said, is an important statutory requirement of the Health and Wellbeing Board. It's actually quite a large piece of work to undertake this mapping. It usually takes roughly about a year to complete the work, because you need to engage with pharmacies, engagement with NHS England, consultation with both pharmacists and members of the public to understand what the pharmacy need is across Shropshire. And for us, it's about making sure we maximise that opportunity around pharmacies. So as I said, the piece of work needed to be produced originally for this March, April. That was paused, that was given dispensation from NHS England that we would pause that, but we've already started the process of delivering that needs assessment in time for the end of March 2022. This year we are collaborating with Health and Recon to produce that needs assessment, working with our CCG colleagues, which is really helpful, given that we've got shared kind of pharmacy resources as we move towards our delivery of our integrated care system. It makes sense that we work at that geography, but we will produce a single needs assessment for Shropshire, as is the requirement of the NHS England and Health and Wellbeing Board, but we'll work collaboratively where we can to avoid duplication and make sure that we can inform that integrated care system work. That work has started. It's been agreed in principle, and the steering group began meeting last week, but as I said, it's quite a lengthy process actually to produce a pharmacy needs assessment. The final element of the work that we're progressing around the joint strategic needs assessment, which we've, as I said, we brought to the board in principle in January. I can confirm that we've started to move on our place-based needs assessment. So again, there's several elements to this to allow this work to progress. The first was agreeing the geographies that we would undertake our place-based assessment at. Our place-based assessment is seeking across 18 geographies across Shropshire. So these are kind of neighbourhoods that have been broadly aligned to communities. So across those 18 neighbourhoods, we will undertake a detailed needs assessment in that community, working with the community and stakeholders in that community to understand the health and wellbeing needs of that area. And when we talk about health and wellbeing needs, we talk about health and wellbeing in its broadest sense. So to understand how healthy and well people are, and what the assets are in that area, and what the needs are in that area, we are taking a broad approach across not just understanding health, but also understanding education, understanding employment, and all those what I would call the wider determinants of health. So housing, all of those things that influence people being in good health and well-being. The purpose being to pull together all the hard data, if you like, so the quantitative data that we've got, but also to pull together that soft local intelligence about what matters to people in those communities, how it feels to live in those areas, what services are already in those areas, not just in terms of services, but the assets within those areas, to understand what needs there are around health and wellbeing, what things we need to do to improve health and wellbeing, what are our priorities in those populations. And by doing that across 18 areas, it's quite a big undertaking, we'll aggregate that information together to understand across Shropshire what are the priorities, across Telford and Wrekin, Shropshire, what are the priorities, but also within those communities, what are the health and wellbeing priorities. And I think the key to all of this is to, as we said, is to remember that the joint strategic needs assessment is joint, although it's led by public health, and in my case it's led by the Director of Public Health. Collates that information is joint. It absolutely is contributed to and owned by all of the partners on the Health and Wellbeing Board, including health, including obviously social care, adults and children's social care. So it's really important that everybody contributes, and what we want to do with the place-based needs assessment is also to make sure this is all communities feel it's their needs assessment, and that they can use that information to become the single source of truth, so people can pull together all those disparate data sets that we've got and try and pull that together into one place. But use it as a way to continue to engage with our communities and to understand their needs, but also feedback on any changes that we need to make to meet those needs. And again, that should be done collaboratively. All of the recommendations will be owned by not just statutory partners, but also hopefully by local communities as well. And our community and voluntary sector are absolutely crucial to this. And just to emphasise again, this is across all ages, adults and children. So in terms of delivering that, it's quite a huge undertaking. The first phase was just to identify the geographies, so the 18 geographies that we would work at, recognising that where we could, we'd get small, lower level data, but we'd aggregate that to the 18 areas and then up as we needed to. The second element that we need to do in order to take this forward is to develop a web-based tool, but that will inform the needs assessments that we're producing. So effectively try and collate all of this information into one place, both the kind of hard data, if you like, that we've got access to, but also soft intelligence around research and other things that are being carried out, so to try and pull that together. And that you'll see that in your pack. We've started to develop some of the information that we want to pull together. I do recognise that we're looking at a web-based tool. That doesn't mean that we're exclusively web-based. The trick is then how we interpret that in our place-based needs assessments, and we can share that in lots of different formats with our communities. And then the third element is actually to start going into some of these areas and undertaking these needs assessments with the communities, taking the intelligence and data that we've got, the information we know from local people within the area, and try to bring that together to really understand collectively what are the needs of those areas and helping to make recommendations for improving health and wellbeing outcomes in those areas. And last week, on Thursday, we took this paper to the Health and Wellbeing Board, and they agreed the 3 areas that we would begin to roll this needs assessment out for our 18 geographies. So we've got 18 geographies. Although the web-based tool will look at all geographies at once, what we will do is the detailed needs assessments when we go into each area, we'll do that in a phased way because we can't do 18 areas at once. We'll do that focusing on 3 geographies to start with, and those 3 geographies are proposed to be Highley, to be Whitchurch and to be Oswestry, for different reasons that are within your paper, but that will allow us to work with those communities, key stakeholders in the area. And when I say key stakeholders, I obviously mean all statutory partners, I mean members within the area, I mean to work with communities within the area to really understand what the health and wellbeing needs of those communities are. And so that's the kind of the summary of the report that I brought today, which hopefully describes the progress that we've made since when we met in January on all 3 elements, on the SEND piece of work, on the pharmacy needs assessment, and as we move forward on our place-based GSNA, and to bring that to the board. So that's kind of summary of where we are. Thank you.
Thank you, Rachel. Just one question I was going to ask first before I throw it open is with regards to the place-based part of the needs assessment. Do we have any? Do we consider at all any of our Welsh neighbours within those 18 place-based areas?
No, so we haven't. We've just included those that meet within. So all 18 are within the geography of Shropshire. However, what I would say is that when we're working, I think Oswestry is an example for where we wanted to do this, where we have a border areas, we would want to consider flow across the borders and as part of that needs assessment. And I think that's part of what makes this unique, and which is why we want to go to each 18 areas, because we really want to understand what is different within each geography, as well as some of the similarities across each geography. So I would envisage when we, for example, within Oswestry, that we'd want to include some of those flows across to Wales within that, We may identify data gaps as a result of that. I suspect we will, and how we would want to make recommendations to improve that. Likewise, in Whitchurch, there'll be flows across Staffordshire and other areas that we would need to consider as well. So whilst the geographies themselves will focus on a particular area, within all of those there will be flow across to different areas, either within Shropshire or across the borders, that we need to recognise and pull through.
Okay, thank you. Right, questions from the floor. So, Chris.
Thank you, Chair. Could you expand more on the financial implications on item 7, please?
Yes, so I think that in terms of financial implications, the cost really of running this programme are much more around the resources needed in terms of analytical support, project support to deliver each needs assessment within each area. We have put additional resource in, so we have brought an additional officer in to help us deliver from the analytical capacity. We're also pulling in resource from our CCG colleagues and other partners where we expect them to bring some of their analytical resources together, and that kind of sets us up for how we need to work across the integrated care system. So the resources, but I think what I'm laying out is a programme that's going to take a couple of years in terms of the place-based needs assessments to complete. If people want to go faster and harder on that, we would need to put additional resources to those that we've already allocated. The other resource implications are really around people's time to run this. Once we've completed and prioritised all of the data and we've identified the priorities, there will obviously potentially be a resource implication as we expect people to take account of the priorities that we've laid before them. And that could be the Shropshire Council, it could be statutory partners in terms of both NHS colleagues, but also hopefully in terms of local communities who may want to redistribute. But I don't what may want to, that's what we need to be doing. We need to redistribute our resources to make sure we meet the needs identified, and that is the whole purpose of doing the needs assessment. So there's some immediate resources that we've identified to deliver this. We need to manage that really carefully, because once we start going into those areas, it'll give us more of an indication of how many, if we need additional resources to support those needs assessments. If we want to speed up the process, we would need to put even more resources in. Yeah, and then in terms of the outputs, clearly we expect that the priorities identified should affect the resources that are aligned to that delivery.
Can I just ask the Chair, what figures are we talking?
Sorry, in terms of staffing resources. So it will depend on analytical support. So if you wanted extra analysts, it would depend on the level of analytical support that we're putting in, whether that's an annual support of 40,000-50,000 to get an additional analyst in to help support. Other colleagues, we need project management support as well, because it does require a bit of, obviously, stakeholder. We're trying to manage stakeholders, make sure that we actually write the report, etc. So again, that could be a similar cost, depending on how quickly we wanted to go with some of this. And I do recognise there's a resource implication for all members, voluntary and community sector time to be involved in this work as well, and we're looking at pulling some of that in from other areas.
Thank you, Rachel. Thank you, Chair.
Gerald.
Thanks, Chair. Something that seems to affect everybody's health, and it's expensive as well, is obesity. Now, childhood obesity and adult obesity has been ongoing for a long time now, and I don't know how successful we've been in tackling this. You able to let us know any figures on that at all?
So, so I guess I agree with you totally in terms of weight management and obesity being one of our priorities, and that is identified. We did identify that in the priorities that we reset in 2019-20, and it continues to be a priority. So that is one of the areas that we're tackling both within the Health and Wellbeing Board and also across Shropshire Telford and Lincoln as well. It's been identified as a priority. So whilst this work is going on, it doesn't stop those priorities being progressed. And so in terms of the actual figures, I haven't got the figures to hand in front of me, although you will know, as you said, particularly in adult obesity, but also in children in terms of our reception and year 6, which is the measurements that we tend to make, that our figures are one of the highest in the region, which is why we've got particular concern in terms of those who are thought to be overweight or obese. So the latest data that I had seen looked like we made a slight improvement in adult weight management, but actually, given COVID and we know what's happened, and given these aren't based necessarily on what's on GP registers and it's based on self-reported weight or weight and obesity, we know that we're storing up a bigger problem going forward. What we are doing, and which we would want everybody's engagement in, is we've started what we're calling a system-wide response to weight management and obesity. And colleagues have started work not only to map what we need to do in terms of responding to weight management and obesity. So yes, Some of that may be services, and we're going to hear about, for example, some of our social prescribing services in a bit. We're looking at our exercise and referral services and how we use our physical activity. So, for example, what's within the council's remit. But we're also looking at a much wider approach, which involves how we use green spaces, how we look at the food environment, etc. So that piece of work has started. It did get delayed because of COVID, unfortunately, but we restarted that piece of work to look at mapping all of the ways that we need to tackle weight management and obesity across the county, recognising that we've got some not only high levels of weight management and obesity, but we're seeing that in our kind of diabetes and cardiovascular data as well. So I guess to reassure this priority, I can certainly get you the most up-to-date figures. We are monitoring those, and that we are working towards that, but having a much wider approach to how we tackle that as a county.
That's good to hear, because obviously it has a great effect on people's health. Now, I was quite shocked when I heard about the young children. When they come into school, they actually put on weight for the first probably 5 years they've been in school. And I would have thought the education they would have then would have rectified this. It doesn't appear to have done.
I mean, again, I think in terms of having a whole systems approach to obesity and weight management, we need to look at all aspects, and we need to go back to even birth, because obviously there's you need to look at kind of weaning, pre-birth, there's issues around maternal obesity, and then it does tend to track through. And I think we've got there's different across Shropshire, and this is why it's so important to understand what's happening in different areas. There's different patterns, if you like, in terms of some of it can be around activity, some of it can be around the calories that we intake. There's obviously links to things like the sort of alcohol intake. There's a whole range of things that are happening. So I think you're right, in terms of working with schools, that's something really important that we want to do, and catering services, obviously, in terms of physical activity, but it's much more than that. It's so much wider than that, and it's the environment we live in. One of the pieces of work we're looking at is food insecurity, so bringing in things like the cost of people of eating healthy. That's, it's staggering really, the variation across Shropshire in terms of being able to afford to provide healthy lunches and healthy meals for our children at school, but particularly at home. So all of that, it's about how we work. We need to take that much wider approach.
Thank you.
Thank you. Kate.
Thank you. I was wondering whether I'm sure you are putting into consideration this. I was just interested in hearing, obviously we've had a very unusual year and a half where we have, during the pandemic, where we have seen the needs for some services really increase, but also a reduction for the needs in some services. For example, people being reluctant to have carers come into households and therefore families picking that up. And I'm just wondering, that could potentially skew our figures moving forward, and so I was just wondering whether you kind of put that in, and whether there's almost a case to look at what's happened during the pandemic and then almost start again, because it's been such an unusual time. And then just linked to this question as well, obviously we've just had the census, and our census data is really old now, and I'm guessing I think we start to get some of that data through next spring, and I'm guessing you're going to wait until next spring before we start to see some of this information.
Yeah, it's really good. So I think in terms of the data, I mean, the pandemic gives us, it's a very unique period, I think, in terms of what will happen in terms of data response, and some behaviours, as you say. And I think what we would always try and do is look at a trend anyway, so we'd obviously try and look back and get the most up-to-date data we can get, and we will obviously take account of what has changed at that point in time in terms of what's happened. I think we need to understand it, because there will be things that will continue, and it gives us certainly an insight into that. I think we will have behaviour changes as a result of it in certain areas. So I'm thinking, some triaging of people wanting to move more online in some areas, but not in others, and it's exposed some of our inequalities, which I think we absolutely need to highlight. So I wouldn't want to not dismiss it, but I think we need to include it, but we need to caveat it with, you need to look back at the trends, we need to recognise what's happening, we try, and we need to, what the JSN is it needs to do, which is often quite difficult, is also try and project what the changes are going to be. So we're doing quite a lot of mapping of what the impact of COVID will be in the longer term. We're going to learn that all the time, so we need to try and project some of that forward to understand what this means for our future planning. So we do need to take that into account, and we need to take that into account of the context that we're living in. And I think that's why the engagement and the conversations with communities and stakeholders is so important, because they can help us interpret some of this data. If you just see raw data, very difficult, and it's that interpretation. So I think that's absolutely crucial. What I haven't said is our ambition. I mean, the ambition for how we change the GSA is a really big piece of work because we want it to be live. We don't want, the reason for having a web-based tool is that we can continually update that data. The reports that we'll write will obviously be written at a moment in time, but again, we want to find a way to be able to keep that up to date through using some of the technology, recognising that we then have to articulate that and allow people to access that in different formats and in different ways. But the purpose of trying to develop a web tool is so that when you start getting the census data come through, when you get other data, we can continually update and refine it. It doesn't become a point in time sitting on a shelf. So it's quite an ambitious program that we've got. It's not going to happen overnight. It's going to be, we're going to keep gradually building on this, and it will be as good as the information people get put into it and how we work together and how we use it as well together. So yeah, so hopefully as we go through the process, we wouldn't stop and wait for the census to come through, but we certainly would, as you say, absolutely have to take into account because we recognise there's going to be some quite big demographic change, particularly from previous censuses.
Trace.
Thank you. Thank you, Rachel. The 3 areas you talked about, and then you said there's 18. Are these sort of linked into these 3 areas? I can't quite get my head around that because I'm just thinking the southwest. Has that got any? Does that form part of this? And if you take into account the rurality issue, particularly in the southwest, which is, you know, that's a key issue for us there. That's my first question. Second question is, a few years ago, we moved to public health, ceased to fund health checks, help to quick, the help to slim. Now, I know some GP practices are still carrying that on. I know we are on our own in Ludlow. Other practices in the rest of Shropshire, are they picking up that funding themselves, or you know, through public health, are you still supporting that? I've sort of lost track really where we are with supporting health checks, help to create help to slim. So I know it was quite contentious when the funding was withdrawn. Some GP practices did pick up the funding themselves. So just a little bit of an update on that, because it's key to this really, because it's much bigger than just seeing patients with that. You see, once you get them in for help to create help to slim, it opens other doors and avenues. So it sort of links into deprivation and other bits and bobs. So just where are we with that, please?
So in terms of the areas, the 18 areas, the 3 that we talked about are 3 of the 18, if you like. So there's 18 geographies across the county. Highly, Whitchurch and Oswestry are 3 of the areas that we would, in terms of the 18. As I said, we couldn't do them all at once because what we want to do is we can collate the data. We'll do that across the 18 areas all at once. But what we can't do is go into the areas, engage with the communities, engage with stakeholders, and interpret that data with the communities and make recommendations all at once. So that's why we've chosen the 3 areas. They were chosen for different reasons, really. We had to start somewhere. I think was the first issue. Highly was picked because it often gets swamped into Bridge North, and so some of the inequalities issues and some of the variation in that area was often underrepresented, I think, because it becomes part of a larger area. Whitchurch was chosen predominantly by health partners because there's quite a lot of development going on in Whitchurch, and it's how we can use understanding the needs in that area to influence some of those developments that are going on. And again, there's lots of issues there we would want to get underneath. And then Oswestry, I think, in terms of some of its links, its border issues, some of the levels of deprivation in that area, some of the strong links and communities that are groups that are already there that we can hopefully quite quickly build on. It wasn't that, and we did debate about whether do we go south, but these were 3 areas that came us quite. We had to start somewhere, and it came as there's a need for us to push on, and this is also about learning in this first phase. How does this work? What do we want these to look like? How does it work in each area? I expect it to be slightly different in each area depending on the communities that you've got. And obviously, once we go through this process, we bring a further update back for yourselves to see the outputs, and we expect to keep refining that process, and we'll agree on those then the next priorities that we want to roll that out to. In terms of health checks, help to slim, help to quit. So health checks have always continued. It's a statutory function, so as a council we still continue to deliver health checks. It's delivered slightly different ways depending on how the practices want to deliver that, and the team will support the delivery. Obviously COVID, everything got paused, and unfortunately that was one of the areas that there was a national decision and a local decision that we couldn't continue to do the health check because of the priorities. We are restarting that programme.
And what we're keen to do, and what we've always been keen to do, is bring that health check programme in alongside other services and look at the model that we have around that. The other area, I think, yes, Help to Quit and Help to Slim in that format were decommissioned, but we have got other offers available, and this comes back to the strategy that I was talking around weight management. So having that whole approach, we do deliver, we have got services that are available, it's just not Help to Slim and Help to Quit. So we have got, for example, we're going to hear about some of the social prescribing work that we've got now, which is now across the county, and that's a much more collaborative way of working out what we need to deliver in each area, recognising as we are through this place-based approach, not every area is the same and it requires the same interventions. And also part of that process is mapping out what's already there. So mapping out things like exercise or referral, courses and programmes that are already there that people are using. So that's why I would have loved to be at this point saying we've delivered that and I can tell you what the outcomes are and what we might need to, for example, commission as a result of that. Obviously, if there's gaps from a public health point of view, we will be looking to fill those gaps and commission where we need to, but we need to deliver that in a way that meets the needs of the community and do that collaborative with partners, because all of the responsibility to try and tackle weight management, this is not just with public health, it's with obviously across actually system partners in the STP, as well as with other local stakeholders. And just to give you a bit of reassurance around that, for example, the smoking pregnancy, we originally said we would decommission that, we didn't, because we recognised it's a priority. We've continued to fund that, and we did a whole piece of work that looked at what is best practice around smoking pregnancy, also the requirements from NHS England, and so we've managed to move that service to now it's based in a hospital service in terms of the smoking pregnancy, based with maternity unit across Shropshire, Telford and Wrekin. The money that we've invested, so we kept our investment in Shropshire, we ran our service through last year, outcomes actually improved, we've now it's moved over to be a maternity-led service, but as the outcomes of that suggested that we needed to have community-based lifestyle services for those mothers, and the commitment is that we will, that is a gap, and that's a gap that public health are working to make sure that we fill that once we've released the money, because obviously Shropshire, STP often, the NHS are funding one element and we will fund the other, and that's a partnership approach, recognising best practice to make sure that we fill those gaps. That makes. Yeah.
Could I just come back? Sorry, you said about you didn't go into the south. I am concerned the southwest again is being. Do you foresee in the future going into that area? Because my particular division of Ludlow East has got the third area size area of deprivation in Shropshire, and that's massive. So I'm just thinking, you know, if you were looking at a need, an area that needed this is it, and I, you know, I think it's a wonderful idea and it's great. But again, I'm concerned that Southwest is being, you know, will that come in the next 2 years? Will you pick up that area?
Yeah, so all 18 areas will be covered, which includes Ludlow, includes all the areas in the south. So obviously at some point we'll be doing more areas in the south than we would be doing in the north or central.
Right.
It was, and you know, so happy we can put Ludlow and other areas, and our colleagues will have different forward for the next week, because we're trying to get different areas that we're working in. But really this was just to start. It was an area with, as I said, greatest need, pressures, if you like, at this point in time, but all 18 areas across the county will be covered throughout the 2 years. So appreciate that, thank you.
Thank you. Are there any further questions at all, Rachel? Or Dean, did you want to comment at all?
Thank you, Chair. I think Rachel's done a pretty comprehensive overview in such a short time. You can see from Appendix 1 the huge scope of the JSNA. But I don't have anything specific to add on top of what Rachel's already said, other than to emphasise the importance of us having an up-to-date JSNA and one that's fit for the future.
Thank you. Oh, sorry,
Yeah,
Kate, yeah.
You asked us to take a look at the appendix and give comments, and I do have quite a few comments, but I think it's probably best that I email some of them, because I'm not sure how good a use of the meeting it is. But I did just want to give one example. So the social care section, for example, which is on page 3, the sorts of information that is listed here is things like active adult users of social care, children in social care, referrals to early help, and these are all good things to have in here. But there doesn't seem to be anything around addressing unmet need, and we know there's an awful lot of unmet need, and there are ways of doing this. Obviously, there's also nothing around unpaid carers, for example. So I was just wondering about the approach of looking at the broader unmet needs that are available, and that's probably some of my comments throughout all of these. I'm happy to email you some of my suggestions, but just if you just focus on the social care points that was made.
Yeah, no, absolutely, really good point. I mean, this is a start. These are some of the harder data sets and some of the starting points, but you're absolutely right. What we need to do collaboratively is look at the gaps that we've got, either because we haven't got the information or it's not easy, or we're going to have to get that through software and intelligence. So, and I think that's why we wanted to share this really widely, because we really welcome people's input. This is kind of starting point. We don't want to keep collecting the same old. We do need that in one place, but what we need is to add to that. And as you said, it's partly about understanding unmet need. Absolutely, and future projection. So where we can work with colleagues in social care to understand what we can put, what more we can include, or what we can flag up as a system where we've got gaps, and maybe look at some other measures. So we'd really welcome feedback on this. It's a long, comprehensive list, but I think there's more. There's always more that we can add, and yeah, particularly the software intelligence. I'm really keen that people some of that.
Thank you, and also just to say, I haven't seen these assessments in the past that have been really broad brush. I really welcome this place-based approach, and it's quite an undertaking to take on. There's a lot of work involved in this, but I hope it will give us some really good results to how we target services in the future.
Gerald, do you want to come back?
Just a request that any emails like that come into you, can we be copied into them and the answers as well, please?
Yes, yeah.
Right. Yeah, Dean wants.
Chair.
Oh, sorry, Chair. Yeah, sorry. Yeah, Dean. Yeah.
Thank you, Chair. Just for Kate's benefit, I chair the Shropshire Carers Partnership Board, which is family carers and unpaid carers, and we have already had tentative conversations about the JSNA. I think the problem here isn't that unpaid carers aren't listed. They're not where you'd expect them to be. They're under health as opposed to social care. So I think that may address that question, but unpaid carers and the board that works on their behalf are absolutely engaged with the JSNA process.
Thank you.
Right, we've got the recommendations for committee members to review the preliminary data and information list on the place-based JSNA and consider any additions, which we've just discussed. Note the proposed work programme and resourcing, and also to consider and approve the proposed Wave 1 place-based JSNA areas. Are we happy with those? Yeah. With the understanding that obviously the southwest will be coming in probably the second phase. Okay. Or second wave, sorry, not phase. So thank you.
Thank you. And just add, I'll pens on for the next item that she could probably pick up some more detail around some of the social prescribed, some of the comments that we picked up previously. I just say following GPP.
Thank you, Rachel. Thank you very much. So we now move on to item 6, social prescribing. Penny. Yeah, if you'd like to come. Thank you. Okay.
Thank you, Chair. So morning, everybody. Thanks for requesting and listening to the presentation on social prescribing, because it's very dear to my heart. I'm very, very excited to let you know about it this morning. So apologies in advance if I get a bit carried away. Before I forget, Councillor Huffer, I just wanted to say, with regard to looking at, I think public health is lucky in the sense that we try, I mean, don't always, definitely not perfect, but to look across the local authority and health to see what's going on where. And with the Southwest, we're doing an awful lot of work around social prescribing in partnership, and you will know, I know you'll know all that. And it was chosen partly as an area because
For example, children and young people is the first area to have a children and young person social prescriber, but that's partly because some of the other things aren't happening in the southwest, if that makes sense. So we know that we're trying to address inequalities across the county, but we can do it in different ways in different areas and then try and bring it together as a whole. But I'll go through that, but just thought I would mention that before I start. So for those who maybe don't know about social prescribing, we started working in 2016 on a cross organisational across public health, social care, primary care and voluntary and community sector to develop a model for social prescribing for Shropshire that sort of took into account Shropshire's needs, assets and local people. And it was happening at the same time as nationally the NHS were really starting to focus on social prescribing, and we knew that there were national movements around developing something for to roll out really across the country. And as far as the NHS is concerned, it sits within the personalisation agenda in the NHS, and funding has been made available through personalisation through into primary care directly. So there's additional roles now as the advent of primary care networks, which are the grouping of primary care GP practices into groups, which in Shropshire we have the South East, South West, central areas called the Shrewsbury Primary Care Network and the North Primary Care Network. So all of that sort of was developing, and alongside that we were looking at how we could develop something for Shropshire that would support that national progression, but also do something that would help local people. And so that programme, we started with a pilot of 3 practices in the Oswestry area. We soon expanded to 11 practices. And now we're really pleased to say that we're working with all the primary care networks, and it's been rolled out across all the GP practices in Shropshire, which is really good. The model was based on adults, although, like I said before, now we're starting to look at how we can support children and young people through social prescribing. It takes into account referrals that come from the GP practices, but also broader referrals come from social care, they come from Job Centre Plus, they come from a range of partners, so we've really expanded our partners. There was a huge amount of work, in fact 18 months really in the first, from 2016 to develop the project, and as part of developing the project we implemented an evaluation of the programme so that we could collect the right data to understand if what we were doing was working. And we worked with partners in the voluntary sector, with communities themselves, with primary care, to put together something that was making the best of all the assets that we had. So we're looking at assets within communities, so what exists in communities that actually really supports those communities and how can we work with them, but also support them. And then people themselves, what assets do people have? And that's the focus of the programme, is working with individuals to kind of draw out their best fit and help people find the confidence to go and do the things that they would like to do and improve their health and well-being. So the model is very much, and we did at one stage apply for an award, and in doing that we thought, well, what does this look like? What are we doing? And what it was a team of teams. So when we developed the programme, we had no additional funding. So we had to draw the best bits from everywhere within our, across our organisations, and with, like I said, no additional funding. So that was like we pulled, and we felt like a team of teams. So we were just bringing in the best from CCG and primary care and public health, adult social care. Data, like I said, is at the heart of it, so that we know that what we're doing is actually supporting people. So when we had the programme evaluated, we had, as you can see in the report, there were 134 people took part and 105 totally completed the evaluation. Which was done by the University of Westminster, and what it found was that there was a 40% reduction in GP appointments during that time, which was, really massively positive. It found that there was improvement in lifestyle, so things like body weight, mass, and the increase in physical activity, and there was high patient satisfaction. And the evaluation found that the programme did what it set out to do, but it also did more than that. So the benefits to the end user were broader than just those kind of health and well-being outcomes. So more recently, we have like everything. It's sort of, I feel like a broken record, but we have been a little bit stumped by COVID and that. But we have had more recent look at the data to find out, because obviously we want to know, is the programme still continuing to help people, and particularly now that we're rolled out across the county. And what we have found is that in a range of different ways we've analysed the data. So we've looked at what we use a tool that's called Measure Yourself Concerns and Wellbeing. It's a very simple tool. I love that because it's so simple. Asks people what their biggest concern is, no matter what they're referred for. So some people are referred for isolation and loneliness, but when they get to you, their biggest concern is that they have debt. So what's their biggest concern? And then you measure that again 3 and 6 months later, and it's measuring the improvement on that. And what we've found is that there is, 71% of the time there's good improvement on those concerns, which is really, really good. There's improvement on well-being. And then also when we looked at specifically those who were referred for for its low-level mental health, and for isolation and loneliness. Again, they have really, really good, that cohort of patients or people have really good improvement on their well-being and on their concerns. So that's, again, just sort of demonstrating to us that what we're doing is the right thing to do. We work really closely with our voluntary sector on this, and in fact, they deliver some of the roles for us. So the voluntary sector do that community development element of the social prescribing, and we work collaboratively, constantly. So they do a number of things. They look at what gaps there are in the provision of activities and things for people in communities, and then they look to fill those gaps. And they also make sure that all those parts, that onward referral from social prescribing to community activity, that those activities have a kite mark. We understand that they've got their safeguarding processes in place. We understand that they've got their volunteering protocols, and we know that they're a good organisation. And we can say to the GPs and others that you can have confidence in our programme and those organisations that we're referring on to. And then another area that we've evaluated looking at the data is those patients. So something else that we do within the programme, that if some GP practices are keen on this, is we support the practice to audit the records for whether it's cardiovascular disease or pre-diabetes. And what we found when we did this in the Bridgnorth practice and Albrighton practice is that 64 people were referred for social prescribing when their HbA1c measure, which is a measure, roughly speaking, I'm not a clinician, it's a measure of your blood glucose or your blood sugars. And people who are in the pre-diabetes range, or people who are not quite diabetic yet, but they're heading in the wrong direction. So those people were referred, 56 of them, they went through the programme with a social prescriber, 56 showed a reduction in their HbA1c, and 40 of them went right back down into the normal range, which is really, really positive. And one of the things that from that we're really keen to explore now is working on those who, there's something called, and things are changing nationally around this, and I don't even understand it myself, but there's something called the patient activation measure. And other areas, when they've used social prescribing alongside the patient activation measure, they've been able to work with people who have a low activation, so people who the scale is 1 to 4. If you're a 3 or 4, you're quite highly motivated. If you're 1 or 2, you're not, your activation, you may be a bit lethargic, maybe a bit ambivalent, you may be a bit not sure what to do next. And those areas that have focused their social prescribing on people who score a 1 or a 2 get really, really good results. So we're really keen to, again, just focusing on being able to do that. So how could we work with a patient activation measure alongside our social prescribing to really kind of move to be getting to those people, to addressing real inequality, so working with people who really need it most. And so that's some of the ways that we can do that going forward. So, like I said, the programme is developing all the time. We're working with the South. We started the rollout with the kind of national programme in mind, beyond the 11 practices, with the South East and South West PCNs. We're now working with all 4 PCNs. The South East and South West are a little bit ahead of the others in that development. So our next phase is really looking with the South East and the South West on how we can work with other roles that are in the additional role within the practices. So the Southwest have asked us to include a health coach within our role. The primary care director there has said, has asked us to look at that and see how we can include that in our wellbeing service that can wrap around supporting people in communities. And we do see this programme as very much working at the heart of communities and really trying to get to grips with inequalities that exist in our community and working with people who need it most. And then, like I mentioned at the very beginning, we have a fledgling social prescribing, young person social prescribing service, which we're really excited about because there's a couple of elements to that. One is that the Southwest PCN again have, we're working with them and we have appointed a link worker, a social prescribing as we call it, a social prescribing advisor to work directly with young people, and referrals are coming from the practice, from schools in particular. And that will broaden out to early help and to others. The other part of that we're really excited about is that we were able to fund additional activity in the Southwest, and we're working with 4 providers of young people's support services. One is boxing. It works with young people around boxing, and then works with them around their emotional and mental health through that kind of medium of boxing. Another is theatre and music organisation in Bishop's Castle. Another is Hands Together Ludlow, who are looking at mentoring service to bolster onto this. And the other is Shrewsbury Town and the Community, which operate in Ludlow for us, and will be starting at the end of August and into the school year to work with young people. And why we're really excited about this is those 4 organisations are working together to get the best of what they do and to be able to share experience. So where the boxing, where Bright Star, the boxing organisation, have this really good toolkit that they use around emotional well-being, and they're happy to share that and work with the other providers. The other providers can increase their skill and understanding of how they can support young people when they come and work with them. So it's really, really positive things going on, and I'm really keen for that to carry on.
Thank you. Do we have any questions at all for Annie? Yeah, Chris.
Thank you, Chair. Can I ask about mental health? Do you envisage this once the new figures coming up? And I was interested reading the report that you say that some of those with mental health difficulties, without being referred, get better. I was just wondering how that happens.
Yeah, so they're referred into, it's something really interesting for us to look at. So they're referred into social prescribing, and their interaction with social prescribing improves their mental health as much as it does if they are then also referred on to another community activity. So we want to understand, is it the fact that people have that one-to-one time with the social prescribing advisor that provides that support mechanism, or how does that work? So we want to understand that more, and so it might not be as clear as it should be in the report, but they are referred into social prescribing. They're just, not all of them are referred on to another organisation to work with them. So through social prescribing, they'll come and have a one-to-one session with a social prescribing advisor. That will last for an hour. They'll have numerous contacts after that on the phone or in person. In that hour, first hour, they really try, the advisor tries to get to know the person, their things that they're really interested in, things that motivate them. And at the end of that time, they might say, well, do you want to come and see me again, or should we have a phone call in 2 weeks? Or are there other things in the community that you'd like to access, that if I sort of show you this list of things that's going on that you maybe didn't know about before, you might want to do? So the kind of how the person works with social prescribing is very varied on that person's interests. And if there's nothing on that list that they're interested in, or actually the thing that they wanted was just somebody to listen to them, then they won't necessarily refer them on to anything else. And that's kind of where the data shows that those people who just come and see an advisor do as well, and sometimes better, than those who go on to something else, which I think is a bit of an anomaly. I'd like to understand that a bit more. Yeah.
Thank you, Penny. Thank you, John.
Carol.
Yeah, this sounds great. It's something I've not heard of before, and it seems to be the ideal thing. I'd like to see some examples of it. I think they can be anonymised. So people with the type of problems they've had and how they've been fixed and what they've been done to make it help.
Yeah, absolutely.
I'd like to see a bit of history about that, see if it's actually working throughout and where it might be fading. And also, first point of contact, do they know about this, and are they able to get involved in it?
Yeah, so yeah, really good points, Gerald. So we have I've got case studies, really happy to forward any of those on to you so you can look and see how it works in practice, because you're right, unless you kind of can visualize something or really understand it, it's hard to know how does it actually work. I mean, one story that I can just off the top of my head is Sarah's story. She was a mum and she had children at home, and she was struggling to take them to school because of her anxiety and kind of concern about leaving the house. And she worked with social prescribing, and through working with social prescribing, she felt, her report at the end was that she was confident, she was taking kids to school, she applied for a job, she got a job, her life was just kind of moving, on the up. And obviously that was coming from her strength within, but she was also helped to get there to do that. And so the stories vary quite significantly. So it's, and I was just looking at the data again this morning, and there's for some of the areas, there's a big cohort of referrals for the age 50 to 59, but then there's referrals younger, and there's referrals over, and it's open for the adult program, it's open to 18 plus.
Certainly seems a great idea, and I'd like to see a bit more of it.
Yeah, we've got Ed.
Good morning. I just asking you a question really. We've heard a lot about the southwest now and the importance of what's going on down there. And I was interested in the earlier speakers, because I'm new to this discussion of what's happening across the county and how you're structuring things. We have a project in Wem that a former mayor set up a charity for, and for children's mental health, young people's health. And I just wondered if you're aware of that, because it's something that's been getting going. I know some aspects of Shropshire Council involved the youth services, for example, the Thomas Adams School and Education. And I just wondered if that was part of your brief or anything you could assist with. We think, as Councillor Schofield's just said, children's mental health is really important in the town.
Yeah. So we're certainly aware that children's mental health is a particular concern. I think it is across the country, but locally, the referrals into mental health services are going up significantly. There's real concern. We are working, so with the developments in the southwest, we're working with our early help with across the local authorities. So within the children's services, we're working with Fran Doyle and with her teams, with Helena Williams, who does outreach, but also with early help. So we are connected in that way, and we're working so that we can make sure that we're not duplicating and we're plugging the gaps, and we're doing where there isn't something. So social prescribing is that kind of upstream, meaning earlier intervention. Then we would want to be seeing children before they get to early help, but it might be that a family is working with early help and one of the children particularly needs that support of early help, but maybe another child in the family could go to social prescribing. So we're really keen to make sure that we've got that kind of cross referral going on, but it is around low level mental health. And although the service will happily work with people who are in mental health services, because we recognise that mental health services might do one aspect, but actually, particularly I think around adult services, there might be other things that people want to get to grips with in their lives, like debt and housing and things that social prescribing might help with. So we will work, but we also want to make sure that we're not a replacement when a mental health service is needed. And I think that we're feeling our way through that. So we want low level mental health we can support with, and we can support people when it's more significant mental health, but we just have to be clear that they're in mental health services. And we're really keen, as you say, to work across all services to make sure that we're working in a way that supports each other. So yes, we are aware of the different things going on to help children and young people. And like I said, trying to fill the gaps and not duplicate, but work with. I don't know if that answers your question. It isn't always straightforward.
Yes, I think I'm feeling my way as well in that I know about this project. I hear about it from a former mayor, as I say, and it's just getting going, and our town clerk has got all the details. All I wanted to do is connect that what's going on with yourselves, that you will look into that and add that into your brief or whatever else you need to do to make sure that works.
Yeah, that would be great. Thank you. Yeah, definitely. And other kind of developments that are going on in the north. So the primary care network in the north is very keen on developing the programme further, for social prescribing to be able to see more people than it currently does, to be able to do it in different ways that suit different audiences, including children and young people. And so things like they're exploring at the moment, which we had some webinars about last week, are group sessions. So how can we bring, when it's suitable for some people to come in a group session, how can we do that and work with the network to do that? So yeah, the north we're working closely there as well.
Kate.
Thank you, Chair. this does all look really promising. It's really nice to see an independent evaluation and outcomes within this report. You know, some of the outcomes sound really good, pretty efficacious. But I've got a broader question about the primary care network itself. Most organisations have someone at the top who you can talk to or engage with. Primary care networks, as I understand it, aren't formally an organisation. And I'm just wondering how, for example, they engage with, you know, we've got health watches, so perhaps they can tell us, but do these plans just roll out depending on how each group feels, or is there patient engagement? And I'm not talking about at practice level, I'm talking about the primary care network level.
Yeah, I mean, that's a really good question. So within the primary care networks, there's a director of every primary care network. And for our programs, we work closely with those directors who work with their constituent body. So they will, you know, they'll have the insight of their GP colleagues and from their practices. And so they kind of understand the general direction of that the primary care network would like to go, and then are therefore able to represent when they're working with us, which is really helpful. And then the way they've kind of developed themselves is that they have often have a lead practice manager on a subject matter. So we then have a lead practice manager that we work with, who again garners the views of the practice managers from the whole PCN, and then we work with them. With regard to the kind of direct, you know, there's probably more work for us to do on patient group interaction. From a public health point of view, we've got meetings actually set up in this month to work with the patient group, the overarching kind of patient group. But with the development of social prescribing, we were very keen and did work closely within communities, and we were sort of developing it to understand, and with the children and young people as well. We had those one-to-one sessions with children and young people themselves, but also when we went in to develop it in the Oswestry area in the early days, having that kind of understanding of people and their views and what they would like. So we've certainly used that engagement to develop the programs. I think there's probably more work for us to do to make sure that beyond the kind of regular person feedback who go through the service, there's probably more work for us to do to engage people on an ongoing basis to understand their views on it.
Thank you. And the directors, are they GPs in the local practice areas?
Okay,
Thank
Tracy.
you. Just to follow on from Councillor Tower, I don't think we've met before. We've been running a similar project in Ludlow Bean the last 3 years, and actually how we've linked in is through the GPs and Hands Together Voluntary. So social prescribing has been very much involved with that. So 3 years on, we've got that, we sort of got that at the right place, how to link in now with social prescribing. So it is quite, we do link in basically, but usually through GPs and the voluntary people that are running it. And I just wanted to highlight, because it works fantastic in the southwest, but then I'm a nurse at a GP practice, so I know all about it. My concern really is, do enough people know about it? I mean, Gerald, you didn't particularly know about social prescribing, so are we getting the information out there? It's easy for me, it's easy for me to access, but is it easy to access for everyone else? And I just wanted to highlight actually the good work that you are doing. I've just had a lady recently that's severely dyslexic. She's 59, couldn't put in a form to get through the home point system because she just couldn't use social media. She didn't know how to type a letter. And I referred to social prescribing. We've got it sorted. She's got through home point. She's just been allocated her first home since an abusive marriage, breakup and losing her home. So it worked fantastically for that. But I knew how to access that. She hadn't heard about social prescribing. So are you getting that out there, that we have got these social prescribers in our GP practices?
Yeah. So that's a really good point, and I think in some ways the pandemic has helped, because things like, I mean, Gerald was asking about first point of contact in the local authority, and that really pushed on for social prescribing, because we were able to ask all the phone calls coming into the council around COVID or whatever, and they could make those referrals. And we've started to have those conversations about being able to self-refer. So people up till now haven't really been, and so from that point of view, we haven't done that big external promotion because we haven't had that self-referral opportunity. It is something for us to think through. We have to be careful about it just for capacity. So we want to make sure that the GP practices still have the capacity that they need when they've got somebody like that there, which is excellent feedback. Thank you very much. That's really good. So I'd like to work with practices on that and see how we can do it, is the answer. But I think it might take a little while.
Thank
Yeah.
you.
Okay, yeah. David.
My question is on advisors. Just wondering, how many roughly have you got across the country? Are they voluntary or are they paid? And also, are they concentrated in any particular area?
So, yeah, good question. So they are across, there's a pretty good split across the whole county, and there's about 12 full-time equivalents across the whole county. They have been funded in a combination of public health and the GP practices. So they are now in the, it's called basically the GP contract. There's additional roles, and so the primary care networks can choose from those additional roles that they have funding from NHS England. So we will have as many social prescribers as the primary care networks are able to fund us to have. So we're really happy to open that up. Public health provides the funding for the management of those people. They provide the kind of development roles as well that we've got within the local authority. And then the local authority also commissions the voluntary sector services that kind of bolster that. So we've got the wellbeing and independence contract that's let through adult social care, but within that contract there's social prescribing specifically in there. The same with our large housing contract that's with the voluntary sector, and the same with the advice and advocacy networks for those that really support people with benefits and advocacy. So those contracts all have social prescribing in them because, well, that all makes sense. We have additional contracts, where the word's gone from my head, we have grant funding that we work with, where we have social prescribing kind of embedded there as well. So from a financial point of view, it's a totally joint endeavour across health and care, which I love because it's the only way that we can actually have a whole service. It's the only way we can afford to do it. And so, yeah, so like I said, at the moment we've got 12 with the bolstered kind of infrastructure provided by the local authority and 12 roles provided by the primary care networks. They're paid, and some of those paid workers sit within the voluntary sector, and about 4 of those roles sit within the voluntary sector, and the rest sit within public health.
Thank you.
Thank you. Okay. Have we got any further questions at all, Penny? No, I don't know if Dean has any comment to make. I'll spring it on you.
Only to say that the social prescribing project has been a great success so far, and it's just about learning from it, building on it, and continuing to improve and develop it. I think Penny's doing a fantastic job as head of partnerships, and that's why it's so important to have roles that straddle both the local authority and the health system.
Thank you. Right, so well, Penny, thank you very much for that presentation, and the recommendation is to note and endorse the progress. We're happy to note and endorse. Yeah, thank you very much. Thank you very much, Penny.
Thank you, and thank you to Dean for your comments. It's a total joint effort with all the stuff.
Oh, I feel like I do very little.
That's good. Okay, we now move on to item 8 on the agenda, which is the work programme. Daniel.
Thank you, Chair. In your papers, there's a draft work programme largely formed up until the municipal year for until April next year. We propose an item in September on independent living, which would look at how we actually maximise sort of independence within Shropshire, and also how we can ensure that said facilities, independent living facilities and capacities available within Shropshire, so people don't have to move out of the area to access those. To support this, there will be 2 briefing sessions happening in August, on the 5th of August and the 24th of August. One with the Service Manager of Commissioning and Governance for services for people with learning disability or a severe and enduring mental health problem, and then one at the end of August with Housing Services Manager and Service Manager for older adults. We're also proposing a review as requested by the Committee of 111 Services on 30th September. In October, we have a briefing session for you on homelessness at all stages as requested. And then in November, there will be 2 items, one on the new direct payments policy and one on health in all, looking at the change in approach to public health within the council, embedding it within services across the local authority. We then also proposed 2 briefing sessions for you on adult mental health services and children and young people's mental health services in November and December, and this is to coincide with what the Joint Health Overview and Scrutiny Committee will be carrying out on these 2 areas. And then in January, we'll be looking at items around joint commissioning, both within Shropshire Council, with partnership with Telford and Wrekin Council, and also joint working with health authorities in Wales. I present this to you.
All right, thank you, Daniel, for that. Yeah, Gerald.
Yes, Daniel, I wonder if you could put something in between there. I was brought back from about social describing when I was working. Probably in 5 or 6 months' time.
And presumably that as well would be with the case studies, anonymised case studies that we talked about.
Yeah.
Okay. Yeah.
Is the group happy for that? Yes.
Yeah.
This committee is.
Okay. Any other comments or inclusions? Oh, sorry.
Actually, so listen, I put this on the Teams group and sent you all an email saying it was on there so you could have a look at it and comment at your leisure. As soon as people are having some difficulty accessing that, I have a couple of you. I am trying to work with IT to get to the bottom of it, but and Kate, actually, after the meeting, I could have a quick look to see what's happening with you. That'd be really useful, but do bear with me, and I will try and rectify this as soon as possible so you can see the work programme at any time within Teams and comment on that as well.
Yeah, thank you, because I must say I couldn't access it at all, no. Right. Any other comments at all with regards to that? Are we happy to agree the proposed committee work programme attached at Appendix 1? Any changes? Well, we haven't suggested any changes. Recommendation, other topics to consider. We have the one from Gerald. Any other comments at all? No? Right. Well, thank you, Daniel. Your report has been fully accepted. Okay, great. Right. So if I can thank everybody for attending, and thank you for Dean for joining in on Teams. Thank the officers for their presentations, and we look forward to seeing you all on our next meeting. Thank you very much.
Thank you, Chair.